So I've been a GP for 20 years and I'm in a very small practice in Bury. In 2006, it was mandatory for all GPs to have a female GP. So I know one of the questions was asked about how you would get menopause care and things like that in your own practice. And if you don't feel comfortable talking with a male, then every practice you should have access to a female. Not saying that this is just a female issue and only female doctors should deal with it. Male doctors should as well, but unfortunately, that's not always the way that it is. So I'm in a small practice. There's 3 doctors, two male and myself, and I end up seeing all the female problems. And I had put into a surgical menopause 5 years ago, and that's kind of what made me more interested in the menopause. And there's a lady called Louise Newson, who you may all be aware of, because she runs a private menopause clinic, and she was on television with Davina McCall. So that's, it did heighten everyone's awareness around the menopause. And for GPs, she gave one free course to every practice in England for a GP to go on, and I went on that course. And on the back of that, then sort of went and educated my practice on that, and I built this talk and then gave it to my sister's practice and things like that. I was sent some pre-questions, which I'll try and answer as we go along. And you can just interrupt me if I'm just waffling and just ask questions. And if not, I'll try and cover them at the end if it's not been covered, if that's okay. So the aims of the discussion is we're going to ask, why is menopause a priority? And there's quite a lot of negative connotations, or there was a lot of negative connotations around the menopause, and the narrative needed to change. And I do think that is changing, definitely. There's a lot more in the press now. There's a lot more being said about it. There's a recent study come out by the Lancet where actually said there's too much in the press about it and women need to shut up and put up, and that's it's very disappointing to read that recently from a very well trusted journal that we all read. But it is a big priority, and people should be made more aware of it. And there is a big disparity in the country of who actually gets menopause care. And I think at the moment only 14% of women are on HRT who should be on HRT, and in deprived areas it's only 2% of women that's on HRT who should have HRT. And after listening to this talk, I believe that every woman who should be offered HRT and counselled properly, and if they want to take it, should be able to take it. There is lots of problems up and down the country with accessing good menopause care, really. But hopefully by listening to this today, then obviously that won't happen to you guys, and you'll know exactly what to say and get some help. So I want to discuss exactly what menopause is, including the symptoms of the menopause, how we diagnose it. I know that that was one of the questions about hormone testing and things like that, and I'll talk a bit about that later on. The health risks of the menopause. So obviously a lot of people associate the menopause with acute symptoms like things like hot flushes and insomnia and things like that, but there's other health risks of the menopause, which are things like osteoporosis and type 2 diabetes, dementia, heart disease, and they're the things that you're not aware of that are being depleted, and I'll talk a bit about that later on as well. A bit about the early menopause. A very important aspect is the genitourinary syndrome or vaginal dryness, which we see a lot of in primary care, particularly with old women with recurrent urinary tract infections, and it's very easily treatable and it's safe, so people shouldn't be suffering. And then a little bit about the impact of the menopause on the workplace, and obviously there's new legislation with the Equalities Act 2010, so your employers do need to sit up and take notice, because it has been put in legislation now that things need to be put in place for people at work. So, sorry, did you say left quick?
Yeah.
Oh, there we are. So, this is just about change in society. So, the role of the woman in society has changed. Now, we're very high functioning, we're no longer just housewives. A lot of us have chosen to have professional careers, so we're having children later in life. We're living longer, so we've got caring responsibilities for elderly relatives. And we've worked a lot, and we're reaching the pinnacle of our careers at the same time as we're reaching the menopause. So it's it's really difficult, to have to deal with all of this, compared to how it was. So, and then it is a relatively new concept, because in 1900 the average age of the menopause was 51, and then life expectancy was only 59, so there was only 8 years of menopausal years, whereas in 2020 the average age of the menopause is 51 still, but the expectancy is into our 80s, so that's 30 plus years in the menopause, which is actually spending over a third of our lives in a menopausal state. And obviously the more research is coming out now, and that's why what we say to patients, what we said 20 years ago has changed now, and HRT and things like that are a lot safer because there's a lot more research and things done, because we're all living older. So to understand the menopause, it is a deficiency of estrogen, and this slide just shows you the influence of estrogen on the body. So it affects basically all systems. It affects your brain, it can affect your heart. So before I said about protection of heart disease, obviously you need it for breast growth and for your ovaries and your skin, hair, for ageing, and then bone, increasing bone density, and regulating cholesterol production. Again, going back to heart disease, and heart disease is one of the big things now in menopause research, but we're recognising more and more so the importance of taking estrogen, especially in the menopausal state, to reduce cardiovascular disease. So this is just a very typical kind of case that I would see in practice. So a 51-year-old lady, she comes to see me with poor short-term memory, poor concentration. This is affecting ability to work. She's also suffering some palpitations. She's had recurrent water infections, and that's more than 2 in a 12-month period. That's the classification. She's got worsening of migraines, and that's very typical to happen if people suffer with migraines. They will get worse around the menopause time, and that's to do with vascular spasm. So that's when we're getting the hot flushes. It's our arterioles flash. We call them flashes, and that's what causes us to go red and feel hot. And it's the same what goes in our brain that brings on migraines. So they can worsen. A lot of people around menopausal age will suffer with symptoms of anxiety and depression, and a lot of people are wrongly diagnosed and started on antidepressants, and the big picture hasn't necessarily been looked at. And a lot, this lady's got a family history of dementia and cardiovascular disease, and as I sort of hinted beforehand, that we know now that there's lots of evidence and research saying that taking HRT can prevent dementia and cardiovascular disease. So menopause comes from the Greek word, so meno means month and pause means stop. The average age of the menopause in the UK is 51, but it can occur any time from 45 to 55. And strictly speaking, it should be no period for 12 months and a day. This is quite important when we're talking about the perimenopause. So the perimenopause can be any time. The average age of perimenopause is 45 to 50, but it can occur from 40 to 50. And it's important to know, if you're thinking about starting HRT, where you're falling into, because if you're perimenopausal, it affects which HRT you take, and when you're perimenopausal, you'll have to take a HRT that still induces bleeds. So a lot of women don't like that, and really the license at the moment is that you can only have the bleed-free preparations if you've had no periods for 12 months and a day. And then premature ovarian failure is if you've got symptoms in less than if you're less than 40 years old, and it's quite common. 1 in 100 women suffer with premature ovarian failure, so it is a very, it's not uncommon. And it's at this point here really when we start to do test and investigations. So who's affected? So as I said before, all women are affected. 80% of women will have symptoms, and 25% of those have very severe symptoms. 50% of all these don't see the GP because they normalise the process. And what's been reported recently, people do think it is just part of a normal ageing process. And as I said before, that needs to change. That rhetoric needs to change, really. And 70% of people, when they were interviewed, didn't realise that their symptoms were menopausal ones, because I think it's just very common symptoms you think of when you associate with the menopause, and really there's lots of others which I'll go through in a minute. So the next thing, so this is a menopause questionnaire which is called the Green Climateric Score, and this is a standardised, recognised questionnaire. So one of the questions was when I go and see my GP, how do I approach the subject? How do I speak to them about it? So one of the things that I bought, I printed off loads of copies. You would fill in one of these, and then that would be the starting point of the discussion with the GP to say that you think you're premenopausal or menopausal, and then you repeat it again after a month, and then again at 6 months, and then again at 12 months, just to look for improvement if you started treatment. So, and as you can see on that, about symptoms. So there's difficulty in concentration, feeling tired, crying, irritability, feeling dizzy and faint, headaches, joint pains, breathing difficulties, loss of interest in sex, anxiety, and then a lot of people do get palpitations and different feelings as well. I don't want to ask any questions about that or what I've said so far, or am I speaking too fast? That was one feedback from my husband, I needed to slow down.
Claire, so can a lot of them be misconstrued as maybe stress or something like that? Is that the common, you mentioned about people not realising symptoms were part of the menopause?
Yeah.
Would it be down to, say, stress, or would it just be a case of not really kind of linking one and one together?
Well, I suppose it's back to when we, jump out to take a history. So I suppose it's about, if I see someone in practice, so someone might come to me with new onset, she's 46, 47, she's suddenly started to get anxious, she's not sleeping very well, and might have a few other symptoms, and because my mind's focused on the menopause, I would start talking about that before I would ask those questions like, does she feel like she's going through the menopause, or are there any exogenous things that are causing maybe stress and tension and things like that could be causing depression or anxiety. So it's about taking the history really, but always having it in the back of your mind that it could be perimenopausal state.
Okay.
And it's just about having conversations. It's about making sure that patients are just really well informed of what's available and what's on offer, because people don't necessarily want to take antidepressants either, really. So so I talked a bit about hot flushing. I can't stress enough, and like I said, the research that's coming out about cardiovascular disease. So we know that the hot flushes are caused by constriction of the arteries, and that's bringing on feeling of hotness, and that's what is causing palpitations. And then you can get scarring. So in actual fact, there is increased risk of cardiovascular disease, raised cholesterol, and that raises your blood pressure, and it increases risk of diabetes.
So can I ask you, is there a difference between hot flushes and night sweats? Or what is the difference? Because
so people sometimes get a hot flush or a flash. It's just that it's an ergo redness and sweating. And night sweats they don't necessarily, they can interchange really. They don't necessarily feel as red and hot, you know what I mean? It's just the bed's just coated in sweat.
Yeah.
That's what most people just report in the
But it's the same thing that's causing it. Is the
exactly, yeah. Okay, so I talked a bit about osteoporosis as well. So it's a very important health risk that happens to all of us, all women. It affects 3 million people worldwide. 1 in 2 women over the age of 50 will have osteoporosis, and 1,200 people die every month in the UK as a result of a hip fracture. So it's another really, it's not only from the heart disease, from protection for osteoporosis. And when I first started 20 years ago in general practice, when we had the Million Women study out looking at HRT, I would probably say to a woman, look, you know, you really need to take it. I was always pro-pushing to take it, but only take it for a couple of years. And it was always, you know, really to protect your bones. That's what we would say to people. And the evidence and all the research papers then actually said it made heart disease worse. So, you know, things have really done a whole 360 on it now. And yeah, so...
How many of the 1,200 people are women that die from hip fractures, or is it quite...
I don't know, I'll be lying to you. I didn't make up a figure if I said that, I don't know. I can find out for you though. Okay, so yeah, it affects his sex and intimacy because the libido is lowered. A lot of that could be from vaginal dryness, so there's lots of, like I said, soreness and burning and irritation. And then that can lead to low self-esteem and less energy, and then that can affect mood as well. And then, so diagnosing the menopause. So it's just really with symptoms. So if you're over 45 with symptoms, or 40 to 45 with irregular periods and vasomotor symptoms, which are the flashes and the flushes, no blood test is necessary. And in actual fact, £9.6 million was spent last year alone on testing for menopause in the NHS. So if you're less than 40 and you've got premature ovarian insufficiency, then you do need blood tests, and you need those 6 weeks apart. And the reason for that is the blood test that we do is we look at follicle stimulating hormone, and that varies. It's not consistent. It fluctuates. So that's why we don't do a blood test. We just go off symptoms and offer you treatment anyway. But if you're less, if it comes on the age of 40, then it has more implications. So we refer you on to secondary care. It's not really something we have to do in primary care. So this was a piece of work done by West Midlands Police, looking at menopause in the workplace. So it said 81% of women said the symptoms affected them at work. 87% stated a supervisor or line manager would benefit from some menopause training. 25% of them had time off work because of menopausal symptoms. 33% considered leaving or reducing, and 25% felt not capable of doing their current role. And then obviously, like I said before, it's quite a sad indictment, isn't it? Because we're probably the most skilled we are, you know, at that age, and yet we're having all these problems, and quite a lot of women think about leaving work and things like that, and really, you know, we've had all this training, and it's sad that we feel this way. So this is by Louise Newsom. She's from her website's called The Balance, and it's a brilliant website, and she's got an app as well that you can go on with information, and this was one of her workplace studies, which had very similar kind of reflections in you know, how it affected them at work. But I think one of the interesting things I thought here was on sick notes, which is bane of our lives in general practice. 52% of them said anxiety, and only 7% of them said menopause. And I think that goes back to training, you know, and like I say, we're not trained in medical school about the menopause. There hasn't really been any training up until the last few years in the menopause, and it's not always necessarily on people's agendas when they're doing professional development. We all, as GPs, have to do 50 hours a year, and you have to sort of tailor that to where your needs are, and yeah, you're not made to do any training.
I actually took her prescribing guide into my GPs because they wouldn't listen to me.
Yeah.
Just to get them to actually look at what I should be on. I felt like I prescribed it myself rather than them, you know, listening to what I was saying and doing something about it. They just wouldn't.
Yeah, so unfortunately, and it's so simple, her prescribing guide, isn't it? You know, to me, and it just says woman's got a uterus, and she's this age, prescribe this, and if you have problems, prescribe this, and it's really difficult. I think one of the problems is it's our FDA really. So even now, despite all this evidence, despite it all being out there, if we as GPs go to prescribe estrogen, so even if we prescribe the body identical estrogen, the transdermal ones that we now prescribe, we know are very, very safe, it will still flash up on our system, increased risk of breast cancer. And if you get a little packet and open it and then read all the side effects, it says it in there, and it's talked about a lot. There's a lot of misogyny that goes on in the health world really, because a man can go into Boots and buy Viagra, and that is riskier than taking HRT. Yeah, got a lot more risk than taking HRT. So and this is what we're dealing with. So this, after the West Midlands Police, this is just a leaflet they put on the back of the doors just to try and toilet doors, just to try and raise awareness of other menopausal symptoms and things like that. That's just a unison link, for guidance. But now, obviously, like I said before, with the Health and Equality Act 2010, there's actually legislation in place now. Saying that workplaces do have to make appropriate adjustments for people suffering with the menopause. So that is things like if it's hot, to get cooling systems, or being able to wear not having to wear uniforms, for instance, if it makes you feel more hotter in different clothing, or if you've had a bad night's sleep, you should be able to work from home the next day and things like that. This is what's in the legislation now, but I don't know how that's easy that is to put in place in a workplace. So there are alternatives to HRT, and these you can get in Holland and Barrett and things. So you can take black cohosh, red clover, soya, so a lot of people take that in soy milk or soy cakes and biscuits, St. John's wort, but really there isn't evidence out there to say that they work. And in actual fact, with black cohosh, I think it is, there's actually been a yellow card now to say that it can cause liver problems. So, and like I said before about the modern forms of HRT, is that it's body identical, and therefore it's actually more natural than any of the herbal remedies that are available. I think I'll talk a little bit on the side on just talking about the previous types of HRTs. I'll talk about it a bit later on again, but just to say about the body identical estrogen that's available now. When the study was done, which is the Million Women study 20 years ago, they used synthetic estrogens, and that was derived from pregnant horses. So that's how they made the Premarin that was used in the study that showed this increased link with breast cancer. Whereas now the estrogens that we use are body identical, and they're given transdermally as well. So they're not given orally, so they don't have to bypass the liver. So there's even less risks associated with it. So just some lifestyle changes that we should all do, men included. Take calcium and vitamin D supplements, especially since we've not seen the sunshine in about 4 months. Reduce alcohol intake, exercise more, obviously eat healthily and stop smoking. All these things are gonna help as well. I've written my little note on here was not only do they make you live longer, but will actually work for symptoms and make you feel better. So who takes HRT? So 75% of women said they didn't know enough to make an informed choice. In 2000, 26% of women took HRT, and then obviously it's sad, isn't it, that 19 years later there's even less women taking HRT. And a third of women didn't think their symptoms were bad enough. And I think most experts now definitely agree that women are suffering unnecessarily, and a lot are given wrong diagnoses. So, why are we scared? So, talked a little bit about the Million Women study, which looked at. Hold on. Sorry. Okay. Yeah. So a lot of people are worried about breast cancer, and just, you know, when you ask women what are they scared of from taking HA, a lot of it is around cancer and heart disease and things like that. So this was an exercise done where we did, part of my training with News and Help was we had to put these in order of what we thought was, you know, the largest cause of death, and put them in order of how. Does anyone want to have a guess at what the highest cause of death is? Just dementia, and then heart disease, stroke. So this is the, you know, the most common causes of death in females. And if you actually look, breast cancer is actually 7th on the list. So, okay, this is the Women Health Study 2002. So, like I said, it was assessing long-term risks and benefits, but when you actually look at the study in a bit more detail, the average age of the woman used was 63, a large portion were Caucasian, were obese and already had cardiovascular disease, and they were using Premarin, which I said before was a synthetic derived estrogen, and that's why you see that big dip in number of people taking HRT in those 20 years, because of this, basically. This is like a schematic that I use in practice. I think it's just really useful to use it. It gives a better understanding around breast cancer incidence. So it's the difference in breast cancer incidence per 1,000 women aged between 50 and 59. So in the next 5 years, there'll be 23 cases of breast cancer just in the general population. There'll be 4 extra cases with women who take combined hormone replacement therapy. There's 4 fewer cases in women who take estrogen only hormone replacement therapy. There's additional 4 cases in women on the combined pill, which is the same then as taking the combined HRT. There's additional 5 cases in women who drink 2 or more units of alcohol a day, and there's 3 cases if you smoke, and then astonishingly, there's 24 cases of women who are overweight with a BMI greater than 30. So in actual fact, you know, being obese really is the biggest risk factor for breast cancer. And then just to promote exercise and things, there's 7 fewer cases in women who take at least 2.5 hours moderate exercise per week. So that can be really useful, just trying to reassure people if they're nervous of taking.
With the contraception and like the pill, and the risks of breast cancer from the pill, is it the same reason as the old HRT, or is it different reasons?
No, it's exactly the same. Yeah, similar hormones are used. Yeah, because they're synthetic, but there is a new pill out called Zoli, and that's body identical estrogen as well. So I transferred most of my patients onto Zoli now, really, because then that goes back to, you know, less cases, because it's not synthetic hormones. Yeah, so they are changing as well. So this is just some examples of how it looks. So we, as I said before, we use it transdermally in either the form of patches or gels or sprays. And it's in actuation, so you can use either 2, 4 or 8 pumps, and then you rub it into your outer arms or inner thighs daily. If you've got a uterus, then you do need to have progesterone protection, because estrogen alone, given over 10 years, will increase the lining of the womb, and that could then turn malignant. So that's why you have to give uterine protection. So a lot of my ladies like to use coils. So I've just bought an example of a Mirena coil here, which can go in as the uterine protection, and that can stay in for 5 years. And that's just inserted. This is my just inserted into the womb, There's a little area on it that's got hormone, and that's just released locally, and that just thins the endometrium out. There's actually newer coils as well on the market, one called Jades, and that has half the amount of hormone that a Mirena has. So we use that mainly in women who don't suffer with dysfunctional uterine bleeding but need some uterine protection. Oops. Sorry, my computer's just decided to close.
Just on that side, at the bottom it says that you need to stop. There's no need to stop.
Yes.
I've been told recently that I won't be able to stay on it long. I think I've been on the ones that I'm on now for about 2 years, but they are already trying to get me to stop.
Yeah, no, that's not, no. You can stay, there's no reason to stop them.
I mean, I've read that in the press and on other things, but
Yeah.
that's my current GP.
Yeah, so I would just ask for a second opinion. Yeah, I'd ask to see somebody else, because that's definitely not the guidance now that's out there. I think we've had, as of all the press and things like that, I've had quite a few ladies sort of in the 60s and 70s coming saying, can I start HRT? And the answer is always yes, you can start HRT. However, you're not going to get as much cardiovascular protection from the HRT because a lot of it's already pre-established, if you know what I mean. But yeah, so yeah, I've got old ladies who want to take HRT and that's fine, and yeah, you don't have to stop it ever. Given in this way, so you taking body identical transdermal?
Yeah, the gel and the tablets.
Yeah, so they're very, very safe. Yeah, so yeah, there's no reason why you should have to stop them. Sorry. One of the questions was about testosterone and the menopause. So it was often thought of as a male hormone, but has essential functions in women and men alike, and the levels do drop off with age. And the symptoms that people report that are recognised is having low energy, low libido, and brain fog. And we do believe that taking testosterone supplementation will help with all those, but unfortunately, again, from the FDA, there's no licensed preparation in the UK, so that's why as GPs we don't prescribe it. But we can refer to menopause, specialist menopause clinics, if and they will prescribe off licence. So I know Louise Newson in her clinics, she uses a natural testosterone from the yam, so it's an Australian testosterone, and she charges about £90 for 3 months for that prescription. And I've got a couple of ladies that are on that, and they just say it's absolutely amazing. And you know, when they work it out, it's like a coffee a day type thing, and you know, it's well worth it. So.
How do you get a prescription for you say you still have to get a prescription for it?
You do, yeah, she has to prescribe it, yeah.
So the
it's
doctor,
through her.
does the GP prescribe it? Or?
No, yeah, she prescribes it, yeah. To buy it from her clinic, because it's not licensed, so we can't.
Okay.
Yeah. But so that's what people have had to do, they've had to go sort of privately for it. I do facilitate with the blood test though, because you're supposed to have a testosterone level done after 8 weeks of taking it. So, but the lady I had in recently, she'd had one done at Newton House, and we did one, and our reference ranges must be different because her testosterone was a lot higher than, you know, but she said the clinic had said that was fine, and then proceeded to tell me how how wonderful she felt. So I thought, well, I can't, she's getting a private prescription anyway, I can't pay the advisor really. And there's no harm for taking testosterone. The only side effect sometimes you can get is hair growth at the site of the, where you're applying it. So
it's a cream?
Yeah, oh sorry, it's a gel, yeah, it's a gel, yeah. So, personally because I was put into a surgical menopause, I don't have my ovaries, that's where you produce testosterone. I've had testosterone prescribed by a menopause clinic, so it's men's testosterone, but it's in a very diluted form, and it's just a faff. You know, having to, and I personally didn't get any benefit from it. So, but I know that that's not what other people have reported, and I would never sort of put anyone off from trying it anyway. So this is where I've got my resources from. Just to slide out. So the take-home messages are, so it's massively underdiagnosed by healthcare professionals. And whether you have any symptoms or not, you will definitely benefit from taking HRT. You don't need any blood tests. It can reduce the risk of CBD, and like I said, if it started early, and it can reduce the risk of osteoporosis, and it's usually topical and it's very safe. And in actual fact, being on HRT reduces all-cause mortality, so it reduces all causes of death just by being on HRT. And
Sorry,
that's
when you say when you started early, do you mean in the perimenopausal phase or in menopause?
Menopause phase, but even menopausal, because your levels are fluctuating then. So there's absolutely no harm in starting taking HRT at all, really. Yeah. And then this is just a leaflet that anyone can get hold of. It talks about myths and facts. And I can leave some copies of that for you all to have anyway, which I think I've spoken about a little bit. And then I've chatted enough, really. Any questions? Has anyone got any questions you want to ask? Or
if you've got some time after, I'll ask you a question or two.
yeah, of course. Yeah, no, that's absolutely fine. Yeah, no, to answer any questions.
In terms of sort of specific things in the workplace that can help support,
Yeah.
are there any, you mentioned a couple before, but are there any sort of like really sort of stand out things that can, that can make a really big impact?
I think obviously just making the environment comfortable, isn't it? So it's, getting the temperature right, really. That's a big thing, really, and about sort of what people are expected to wear to work.
Yeah.
Make sure it's not constricted and things like that. Being flexible, do you working from home and things like that?
Yeah.
I don't know if you offer that. That's an easy win.
And you had a previous statistic that showed people's sick notes, they, I think it's 52%
Yeah.
anxiety.
Yeah.
So does that mean that people are, what that's inferring then is that women are maybe more comfortable saying that they have anxiety issues than
Oh no, I think it's underdiagnosed, to be
Okay.
perfectly honest.
Oh, so that's
Yeah.
the GP.
I think it's the patient not being informed. So our job is to give information, isn't it, and empower women to make
Yeah.
decisions. And even we've had a new GP in our own practice that started, who's he's a salaried GP, and already I've had to go down into his room several times to say, actually, no, that's not right, do you know what I mean? And he's giving information out to women who I've given HRT, and then he's tried to give the women's health information to them because he's not necessarily been trained and things like that. So yeah, I think it's to do with who you see, and if it's there in your mind to bring it up in conversation.
Yeah.
So straight away I will know. Looking, I've been in practice for now nearly 20 years, so I know all my patients. It's a small practice. I know a lot of my patients, and when they're coming with about 48, I can almost predict what they're coming about. And I will have the conversation with a lot of them as well. Talking about HRT, sort of saying, think about it for, maybe you don't want it now in the perimenopausal state, but certainly when your periods do stop and you officially become menopausal, I would definitely come and see me again, because I definitely think you need to go on HRT. Yeah. And then obviously then you get the fallout, because when you start HRT, one of the side effects is that you can bleed a little bit. And that can happen for the first 6 months. I don't know if you've had any problems like that. So then I get all those, you have to then investigate, and it goes on for longer than 6 months. It has created a little bit of extra work because, people started bleeding again and think, that it's not completely symptom free.
Yeah.
But we've not had any cancers or anything like that, if you know what I mean. I think it's just getting the levels, the balance of giving the hormones in proportion correctly.
Okay.
Because we can be very flexible with the level of estrogen we use, whereas the level of progesterone is standard. So it's either the Utrestogen, which you take at night, the tablet, which is sedative as well, so a lot of people like taking that because insomnia is a big part of menopause. But that's a standard dose. You can't take 2. And obviously the coils, like I said, you can step down on the level of hormone from the coil. That's the other form of progesterone. Whereas the estrogen, the standard dose is 50, but you could go up to 400, 600, depending on symptoms. And that's symptom led. The evidence at the moment is saying about 50 micrograms of estrogen is enough to give you all the protections that you need. But I have got some women that are on about 400, maybe 600 milligrams, just trying to manage their symptoms.
Okay.
Yeah.
And there seems to be, there's no sort of, are there indicators for who might suffer from worse symptoms, or?
No, not really.
So really sort of like pot luck almost.
Yeah, and it can just affect anyone completely out of the blue as well. Like, I had one woman come see me, just couldn't drive anymore.
Right.
She felt so anxious, she just could not get back in the car. And you know, that was what she came to see me about. And then when we explored things a bit further, and then we started on some HRT and things like that, she got back into driving again. But that took a long time.
Is there anyone who can't take HRT? Any
So-
medical conditions that could prevent you from taking it or anything like that?
Yeah, so estrogen receptor positive breast cancers.
That's it.
Yeah. So, and even then, that's a conversation.
Okay, so
Yeah,
a
it's
doctor
not a
can
complete
use-
contraindication.
Okay.
Yeah, it's not. Yeah, it's conversation about managing risk, really. And some people suffer so much they don't want to live 10 years like that. They'd rather, you know, have HRT and have, you know, a more comfortable life, really.
Yeah.
Than have to suffer with all the symptoms. So
So if
it's about counselling women appropriately.
So if you have menopause and you go to the doctor, they can't really give you any good excuse to not prescribe you HRT.
No, so I've got lots of women that have maybe got hypertension and I just control the hypertension and then start the HRT. And it's about doing whole health. It's like, you know, a holistic health assessment really when someone comes to see you and try and reduce all cardiovascular disease risks really. So it's about measuring cholesterol, weight. You know, some people about weight's really important and trying to, you know, prove lifestyle advice as well really. So yeah, no, there's no reason why anyone shouldn't take it.
Is there any work being done to change GPs? Because, you know, I've been going with these since about 10 years, and even now the doctors have changed it. The female GP does not want to talk to me about it at all. I feel like it's getting the GPs to have the same messages.
It is, and it's about training, So, and like I said, Louise Newson, she did pay for one GP from every practice in the country to attend her. It was quite an intensive course that she ran, but it was really, really. I mean, I wanted to know as well for myself. You know, I had my own interests as well, but and that was offered to one person from each practice. So there should be somebody who's, you know, well versed in it. But like you say yourself, you just find the information yourself and you take it to them, don't you? And then you just have to ask for a second opinion. Or if you're not getting anywhere, there are specialist menopause NHS clinics, so you can get referred to one of those if you feel like you're not getting anywhere in your own practice. But yeah, I have the same frustrations.
So following on from that, this is a perfect example, but I'm also asthmatic. There's certain GPs that are specialisms is in asthma, and similar to this, like yourself. Are there any ways of us finding out what our GPs specialise in? Because, like John just said, then if she wants to speak to a GP that's got a little bit more exposure to menopause and so on, could she just up sticks and try and visit them instead?
Yeah.
Is that possible?
We don't publish it, you know, and we've all got our areas that we're in charge of in general practice. So, like I look after sort of dementia. We're a small practice. I've got like 5 areas that I'm the lead in. I'm the lead in safeguarding and women's health, and my partner's in, you know, sort of chronic lung disease, and so there will be somebody that's in, you know, is in charge of that chronic disease area. But how good their training is, I don't know.
This is only 2 GPs, it's a male and a female one.
Yeah.
And I was with the male one at first, but I've been transferred to her, and I'm still not getting anywhere. She's sort of tests for, she's ruling out everything else now by doing
it's just a
tests
waste of
and
money,
tests.
yeah.
And I'm sure it's just, you know, something that could be sorted.
Maybe think about changing GPs then.
Literally just changed. Yeah, and they
It's not right.
That they had investigating things. I couldn't even get an appointment before, so but they're doing blood tests for other things, and now then you've got to wait for that and for them to exclude it, and that's with the woman GP.
Yeah, so now there's a lot more we call them R's roles in general practice. So you might go to your practice and you might have like an advanced nurse practitioner, or you know, a pharmacist, or we have a pharmacist, an advanced nurse practitioner, and a paramedic, and both the paramedic and the advanced nurse practitioner both will prescribe HRT in my practice. So you could maybe ask first, you don't necessarily have to be a doctor, as long as they can prescribe. And it depends how it goes back to education, doesn't it? It depends how But you can just print stuff off and take it into them. Yeah. Always works. Hello.
I got a couple of style questions.
Yeah.
What's estrogen cleansing?
Estrogen cleansing?
Yeah, and why do people talk about it?
I've not heard of estrogen cleansing before.
Oh, so I keep seeing this on different websites. So there's a few websites that sort of talk about menopause and a few of the things that you can do to help you, and the estrogen cleansing is one of the things that they're selling. So something that helps that. So to me it's like, is that because they're saying that you've got too much estrogen and you need to flush it out? That's how it appears to be, but alongside that they're sort of selling other supplements and that are supposed to help improve the mood, improve your
Right. Yeah, I don't think they're not recognised anyway. Do you know what I mean?
Yeah.
So I can't comment on it really because I don't know anything about it.
There's that much information going around that it's how do you know what?
Yeah, to get a trusted site.
Yeah.
So her site is brilliant. It's called the Balance website and the Balance app she's got, and she does collate a lot of information and she interviews lots of people, and yeah, she just fly the flag, you know, and yeah, that's what I'd say. Sorry, I can't answer that any further. Is there anything else, or is that it? Sorry, yeah.
Is there anything that you mentioned the vascular constriction, was it?
Yes.
Causing hot flushes.
Yes.
Is there anything that specifically triggers that? Can it just happen at any time?
The
or?
FSH fluctuation.
Right. Okay.
So yeah.
So what's a practical? Is there, just so someone's having a hot flush, is there anything they can do practically there and then, or just wait it out?
Well, it's trying to help them cool down really. So you know, having a fan, you know, letting them go for a walk outside, you know, leave, walk outside, having some water. But yeah, you can't predict
So
when your FSH is
down,
gonna. You can't predict when your FSH is gonna spike, fluctuate. Yeah.
Why does the absence of estrogen actually cause that constriction?
The absence of estrogen.
You said that the lack of estrogen.
So it's to do with so it's to do with. It's quite complicated, but it's to do with something called leukotrienes that are released from the lining of the blood vessels, and then that causes narrowing and causes plaque formation, and yes, it's to do with cytokines.
The HRT then is there to stop that from happening, basically. Yeah,
because it's depletion of estrogen. So that's what. So what happens is in the perimenopause time, the FSH just spikes up and down, and then when you finally, and that's when you get the irregular periods, and then you can. People sometimes stop periods when they're sort of 58, 60 even. When you've not had a period for a day in a year, that's officially when you can say it stops spiking. You know, a lot of people's FSH stops spiking then. And those symptoms then do settle down.
And there's no way sort of like predicting when that level's going to change. It can just happen any time.
Yeah, and there's no point in doing blood tests because it does vary. You know, it does vary. So yeah.
So once you've reached the menopause,
yeah.
Do they stop?
They lessen. I don't think they stop necessarily. They lessen.
Right.
And certainly HRT definitely helps with all that. The right dose of HRT certainly helps with that.
So why do you have hot flushes and night sweats if they're the same thing? Because I've never experienced a hot flush, but
Yeah, I'm the same. I'll wake up absolutely
drenched, but not you've not had that sort of.
But I've
feeling.
not had in the day. Nothing. Never have it in the daytime.
Yeah. So everyone's different, and you know. And, yeah, to do this that's to do with your cortisol and your circadian rhythm. So the cortisol lowers overnight.
No.
Maybe that makes
That
you
probably
more susceptible to it.
Yeah.
Yeah. Did bring a vaginal ring as well. this is just a side point. This is just the prolapse.
What a great way to break the silence.
Can't get it open. So, and it's just inserted into the vagina. So it's quite flexible.
What is it for?
For vaginal prolapse.
Oh.
Yeah, so if you've had, you know, sort of vaginal births, or sometimes your back passage can bulge into your vagina, or your bladder can bulge into the vagina. It can just sort of hang down a wee bit. So this is put in place to hold it all up, to hold it all
Surgically,
up.
or do you put that?
We do it in practice, we just do it every 6 months it gets changed. And this is what, there's a contraception as well, I think I called an over-ring, and this is exactly the same as this. Yeah, so you switch it and then insert it, and that's a form of contraception as well. I just thought I'd mention that, you know, it's available. Along with surgery obviously as well, you can have surgery. It's worse.
What would you say your views are on hormonal contraception in terms of, obviously, they're quite risky, at least the ones in the past, in terms of side effects and
The DVTs and deep vein thrombosis and vascular risk.
yeah, all that sort of stuff, breast cancer, whatever. Do you think that the hormonal contraception has improved?
Yeah, so that's the about slowly really. Yeah, now we're not using synthetic hormones. So if you've had issues or problems, then just has to be switched onto. You know, and before that, women used to try the patch, you know, the Evra patch, to try and get away, you know, to try and lessen symptoms. Because we know that given transdermal, it doesn't bypass the liver, and therefore then it doesn't have clotting risks that go with it, so it doesn't increase your clotting factors. So one of the things with the pill can be increased risk of deep vein thrombosis and melanomas and things like that. So that's ways we get around it. But now, if you have body identical estrogens, the risks are much lower. So yeah, it is improving, and there's lots of things about men's contraception as well now
Hopefully.
coming out. Yeah,
They can take that. No.
yeah,
We've done enough.
exactly. Okay.
Yeah.
Yeah.
Brilliant.
Okay.
Yeah. Does anybody else got any?
Okay. I hope that was all right. Sorry.